So there's our side port incision. This patient obviously has pseudoexfoliation and doesn't dilate well. Just keep looking at one of those three lights. Although I'm stabilizing the globe with my left index finger, she's got something to look at. And I'm just going to wipe off that mucoid strand that was there. So I'm going to stain her anterior capsule, and then I'm going to enlarge that pupil. But I'm just going to lift the iris up just a tad. And I'm going to use lidocaine here. You're going to feel a little sting for a few seconds. And now, usually Pseudox, the pupil won't enlarge very much with the OVD. You can see here, I mean, maybe we got 1/4 of a millimeter. So I'm going to do the pupil stretch technique here with a beeler. Hook it, slide out the 2 prongs, engage, and then stretch it. Now I'll take the second OVD injection. And that's Provisk. Put that in. Now those of you watching in 3D may be able to tell that there's a convex anterior capsule. Probably because of zonular laxity. So let's watch to see that we can maintain this capsular excess. Keep it from running out, because it will want to. So I'm pulling more centrally than I am peripherally. Now we're okay. I'll need you to have a cataract support system available. Because the chamber is moderately shallow, I'm just going to put a little more OVD in. It deepens minimally, but minimally counts. So let's see if we can just complete this capsular excess now. And I'm making a small one on purpose, folks. For 2 reasons. 1, I don't want it to run out. And 2, I want to have plenty of capsule to grab. So I know this zonul's really lax. So I'm going to go with the MST retractors here from the get-go. Make our 4 punctures. And the plan here is to use a multifocal lens. So we definitely want to be able to put it in the bag. So preserving the lens capsule here is very important. Now in these shallow chambers, putting them in is a bit of a challenge. Let me have a spatula. Because of the angle. So if I put this in and rotate her eye downward, it gives me a better angle to sneak over the iris here. Now the deal with these is to set them so that they just approximate the edge of the capsular excess. They don't distort it. So they're really not capsule retractors as much as they are capsule fixators. But the nomenclature has been established as capsule retractors. Let's see how we do here getting this one in. Spatula. getting it over the iris here is a little tricky. Arms. But that's good. When you see pseudoexfoliation, a convex anterior capsule, a moderately shallow anterior chamber, a pupil that doesn't dilate well, and a capsule that's lax when you do the rhexis, those are enough. So the first time I put in these capsule retractors is pretty much when I think I might need them. Yeah, you could wait until you're sure you might need them, but then sometimes you wish you put them in earlier. So I prefer to take the time and do it. And the concept really is that these are a temporary lens zonule, meaning they're going to hold stuff in place so the zonule gets no stress during the procedure. So even if you could get through it, hydrodissection, there'd be a price to pay in terms of losing some zonular fibers. All right, so now we're ready to do hydrodissection and then viscodissection. And here, you know, we do viscodissection 360 degrees. And the only way to get subincisional, of course, is to go through the side port incision, like so. Okay. So now we're ready to enter with the phaco instrument and then the chopper. So I'm going to take some cortex off the surface here. And some of it had floated into the anterior chamber, so wet the cornea now. So we got a good view with that cortex removed, and I'm kind of like stabilizing the nucleus with the chopper by reaching into the bowl instead of going out over the equator, which I'll do in a minute here to begin the chop. So there we go. Let's go to quadrant removal. So as I like to do in these eyes with pseudoexfoliation, as soon as I create a nuclear segment, prefer to get it up and remove it. Because that little defect, wet the cornea please, decompresses the capsular sac. And everything we're doing here was with the goal of preserving lens zonule sculpt. So I just did an impale chop. We'll do one more. And back to quadrant.
Quadrant removal.
We'll never know, nor do we want to, how difficult this procedure would have been to do without those retractors. I will tell you, and I think there'll be evidence in a moment, that it would have been a lot more difficult. So I'm using the chopper to hold back that flaccid posterior capsule. And I've got to take a moment here to get this thing to shift past the that retractor, which is a little tricky to do. Let me have OVD. I'm just going to reform the chamber here a bit, and then I make sure that I can slip the chopper out. Now we need INA. Some fluid is getting under the conch. Could be through either one of these or the edge of the phaco incision. So if you just spatula, please. Make that cut down, if you will, and then just do a little bit of milking out of the fluid. Now that'll be significantly flatter. And if any more fluid accumulates, it'll just run out through there. Test infusion. Get good flow. Good. So now let's continue to be mindful as we remove cortex that we'll probably have a flaccid posterior capsule. And we'll protect it. And we're going to have a capsular tension ring ready because we're probably going to use one. So there's, wet the cornea, please. That posterior capsule is predictably very flaccid. I think we're getting a lot of chemosis from the punctures, and I'm going to flatten that again in a minute. A little bit of wet the cornea again. It's the last of our cortex. Okay. So I'm going to get aggressive now and get rid of that chemosis. And let's just adjust this guy. Side port blade. And I'm going to get rid of it from a number of locations. Okay. So I'm now going to just adjust the position of this retractor before I put in the capsular tension ring. So now we're going to inject the capsular tension ring. I'm going to use this spatula right there to just fixate the globe. And now the injection. And this, I'm going to use the spatula. You can see the trailing part of this CTR didn't quite make the journey. There it goes. Now we're ready for the IOL. And this is a 33 diopter lens, and we're using a C cartridge. So I'm going to actually take this 2.4 and make it just a scooch larger. Okay, good. You can see, by the way, how much the conjunctiva has flattened. It's not an issue anymore. And wet the cornea. So there's our Panoptic's intraocular lens being inserted into the capsule sac. And we'll let it unfold. Encourage that haptic to make the trip. Okay. So now we'll remove these retractors. And those of you watching in 3D could see there's no comparison to chamber depth now. It's a normal depth chamber without that large and round crystalline lens. Let's take out that one. And here goes our third, and make sure you get it past the capsule before you pull it out. Let's grab this and just pull it out the incision. One more to go. The vertical ones sometimes are easier to do this way because if they're a little deep set, and she is, the angle is better to pull them out temporally. Alright, so now we're ready to just irrigate the OVD out of the anterior chamber. That's BSS. And whenever you use these or any other retractors, make sure you irrigate the angle where they were, because that's where little pieces of lens like to go and hide. See that one? Yeah, I hate it when I'm right, but there you go. Yeah, they go and hide there because fluid wants to run out alongside the retractor during the case. And I'll syringe with the myostat. And so it'll carry little lens material with it over to those spots. So this is myostat because I know I've left some OVD probably in the lens capsule. So we're nearing the end here. I'm just going to hydrate the side port incision. The conjunctiva is now essentially flat. The IOL is well centered. There's no pseudophacodenesis. Things look good. You can see little fragments behind the IOL in the anterior vitreous there, and there are a lot of them. And that's, of course, due to infusion misdirection syndrome through an incompetent zonule, but those are no consequence whatsoever. And we're done.